Thank you. Good afternoon. Because we are offering continuing medical education credits for this event, I am required to let you know that neither myself as the moderator nor Drs. Grates or Dalal have any conflicts of interest to disclose at this time. Dr. Dorr would like to disclose that he receives royalties for non-exclusive licensing from Oregon Health and Science University to various entities. The format of this session will be 3 20-minute presentations followed by a 30-minute question and answer period. Please feel free to submit questions at any time during the presentation. And with that, I'd like to introduce the first speaker for today's event. Dr. Ilana Grates is currently a data analyst at Kaiser Permanente, Northern California Division of Research. She recently completed her doctorate in health services and policy analysis with a specialty in organization from the University of California, Berkeley. This fall, she will start a new position as assistant professor at the University of Tennessee Health Science Center. Dr. Grates' research interests include electronic health records, benefit design, and organizational culture and their effects on clinical care. With that, Dr. Grates, you can begin.
Hi. Hi. So today I'm going to talk about research that we did at Kaiser Permanente, Northern California, where we use surveys from primary care clinicians to examine the combined effect of team member relationships and use of integrated EHR on a number of key clinician-reported measures of care coordination. And first, I'd like to acknowledge my co-authors and collaborators. As everyone in this call probably is very aware, electronic health records have a tremendous potential to improve care quality and delivery and the overall efficiency of our healthcare system. And because of that, the federal government has committed to spend a large amount of money to promote the widespread adoption and use of electronic health records. Individual physicians who meet the criteria for meaningful use are eligible to receive over $60,000 in financial incentives. And these incentives will eventually turn into financial penalties if they fail to implement EHRs. And the specific criteria for meaningful use was developed to target improvements in both overall care quality and care coordination specifically. And thanks to these large incentives, the number of physicians using EHRs have increased rapidly in the last couple of years, from just 17% in 2008 to 40% in this last year. Still, despite all of the promise of EHRs, the evidence showing clinical benefits of EHRs on care quality and care coordination has still somewhat limited, and some of it has shown conflicting results. And one of the main ways that EHRs are expected to improve care quality is through improvements in overall care coordination. And various models of care coordination usually rely heavily on the primary care team to really take charge and be responsible for the coordination of care for patients. And primary care in the United States has been increasingly provided through the use of multidisciplinary primary care teams. In 2001, the Institute of Medicine published a seminal report which called for a redesign of our healthcare delivery centered around the use of primary care teams. And since then, the use of teams in primary care has really grown. And I think it's going to be increasingly important in the next couple of years as the demand for primary care increases with the take-up of insurance through the American Care Act, and we're still facing a severe shortage in the numbers of primary care physicians. In terms of what the actual teams look like, their compositions can vary widely. Even within Kaiser, there are teams that have, just a couple of physicians and nurses to teams that have a wide variety of different care providers, including, educators, behavioral medicine specialists, and, even other types of providers that are not on this list. There are many care models that, especially those focused on providing a high quality coordinated care for patients with chronic conditions that really promote the use of multidisciplinary care teams and health IT to make sure that this happens. And these include things that have been around for a long time, like the chronic care model, and also more recent models of care like the patient-centered medical homes. And on the more theoretical side, there's a growing body of literature that's emerged in the last 30 years across different sectors, which has really shown that the organizational environment, and specifically team culture and team relationships, are extremely important for the collective learning process and for successfully adopting new technologies. Still, no one has really looked at how the organizational environment, and more specifically how relationships among team members, can modify the effect that the EHR has on different outcomes. I think one reason that it's important to understand the organizational environment is the fact that electronic health records are only a tool, and they clearly provide physicians with more information and new channels for communication. They can also result in some less desirable unintended consequences. So at Kaiser, we asked clinicians after they started using the EHR to describe any facilitators or barriers to care coordination. And even though a couple did say some positive things, for example, one said that now primarily using the EHR across all providers, which has helped a lot, less gets lost through the cracks. Another physician said that it made it easier to check on hospital course, tests, discharge summaries, consults, etc. But still, many reported being overwhelmed by the amount of information. And this is one unintended consequence that has been reported across a number of different settings and seems to be fairly common. So, for example, one clinician said that there's so much information and repetition in this system that it's easy to miss the important points. Another said that handoffs continue to be a problem. Communication is still needed, not just relying on the EHR messages. Information is generally available, but sometimes hard to access, that is buried and not easily found. So, it's easy to think that more information is always going to be better, but that's not necessarily always the case. I think it needs to be presented in a way that is intuitive and that highlights the relevant parts of the information so that important points don't get lost. And an important way that the team environment can help clinicians become better users of the EHR is through its effect on the informal learning process. And this is a type of learning that's reinforced through the strength of working relationships, where clinicians working in a team with a more positive work environment maybe feel more encouraged to learn through trial and error, and also to share any best practices or mistakes with each other. And the sharing of best practices and mistakes is extremely important for really speeding up the learning process. So at Kaiser, even though all clinicians received the same formal classroom-style training on the basics of use of the EHR before the EHR was launched, when we asked clinicians how they learned to use the EHR, almost everyone we talked to referenced these more informal channels of learning. So, for example, one clinician said that colleagues taught me more than formal presentations. Another said, mostly by practicing, trying to solve problems, talking to other people, and a lot of trial and error. And lastly, I learned the most from colleagues. It's helpful when we all meet to share knowledge. So I've been working for a number of years with my team at Kaiser, looking at the various ways in which the EHR impacts healthcare delivery and care quality. And a couple of years ago, we published a paper which showed that the EHR was associated with improvements in a number of clinician-reported measures of care coordination. And more recently, we published a paper that showed that the EHR was associated with improvements in clinical care and outcomes for patients with diabetes. So in the past, we already showed that the EHR was associated with certain measures of care coordination. And today I'm going to talk specifically about how relationships among team members in primary care modified the effect that the EHR has on these care coordination outcomes. The study that I'm presenting was conducted at Kaiser Permanente in Northern California. Kaiser is a large prepaid integrated delivery system, It provides comprehensive care for over 3 million members. In Northern California, we have 17 large medical centers. These are centers with a hospital and about 110 affiliated primary care teams that are affiliated with each medical center. The EHR system that Kaiser implemented is a widely used, commercially available Epic-based system. Epic was one of the first EHR systems to be certified as a complete EHR, making its users eligible for the meaningful use incentive payments. And like all complete EHRs, Kaiser Systems provides clinicians with the full integrated patient clinical record at the point of care. It has a number of different tools for the clinical decision support. It has computerized order entry for both labs and prescriptions. And it also provides clinicians with secure messaging to communicate with patients and with other clinicians. This figure shows the implementation timeline of the EHR at Kaiser. Each row represents a different medical center. And you can see that the EHR implementation was staggered by medical center, first with the outpatient EHR, which was followed roughly in the same order about a year or two later by the inpatient EHR, at which point each medical center had the full integrated outpatient-inpatient EHR available. And for the study I'm presenting, we collected surveys at 3 points of time during the implementation. So once in 2005, before the implementation started, in 2008, kind of in the early stages of the implementation process, in 2006, and then again in 2008. And to look at care coordination, we asked each clinician how often does each of the following occur when care is transferred across delivery sites. So from the hospital to the outpatient team, for example. How often is all of the medical information available? The information transfer is timely. Do clinicians agree on the patient's treatment goals and plans? And do they agree on each other's roles and responsibilities? And from these 4 questions, we came up with 3 binary care coordination outcome variables. I decided to combine questions 1 and 2 for 2 big reasons. One, I think for the information to be useful, it needs to be both complete and timely. And second, responses to these 2 questions are very highly correlated. And to look at team member relationships, we asked each clinician whether they agree or disagree with the following 4 questions. When there's conflict on this team, the people involved usually talk it out and resolve the problem successfully. Our team members have constructive work relationships. There's often tension among people on this team. And lastly, the team members operate as a real team. And to come up with a team cohesion score for each team, I first took the mean response across these 4 questions for each respondent, and then took the average again over all of the respondents from the same primary care team. So then I had 1 score for each primary care team, which I categorized into quartiles. And this is just a histogram of the team cohesion scores. And then I created a binary indicator variable for teams in the lowest quartile. And from the survey, this slide just shows the characteristics of the clinicians that responded to the survey in each year. And I think the most important thing I want to point out in this slide is our response rates. So in 2005, we were still learning, but we got close to 50%, which isn't bad. But we learned a lot, and in 2006 and 2008, we were able to get over 60% each year. This slide just shows a couple of characteristics from the teams. You can see on average in 2005, they had a little bit over 11 clinicians in each team, and that number went down slightly in 2008 to just under 10 clinicians per team. And team cohesion score remained fairly stable throughout the 3 years of the survey collection. To analyze the data, I used logistic regression with random intercepts for the clinician and medical center levels. The outcome variable of interest, again, were the three clinician-reported measures of care coordination. So 1, having access to complete and timely information. 2, clinician agreement on the patient's treatment plan. And 3, clinician agreement on each other's roles and responsibilities. The main predictor of interest was the interaction between use of the integrated outpatient-inpatient EHR and the team cohesion indicator. And then in my model, I also controlled for the study year to control for any secular trends that were unrelated to the EHR adoption and a number of clinician characteristics. And on the next slide, I'm going to show you my results, but instead of presenting them as odds ratios, I use the results from this regression to calculate adjusted probabilities of each outcome by level of team cohesion and use of the integrated EHR, which I think gives you a little bit better an idea of the magnitude of the effect. So here are my results. And just to orient you a little bit, the white and gray bars show the probability of each outcome, the adjusted probability of each outcome for clinicians not using the integrated EHR, and the blue bars is each outcome for clinicians who are using the integrated outpatient-inpatient EHR. And the lighter color represents clinicians working in teams with lower cohesion. So going through the first outcome, agreement on roles and responsibilities, you can see that before EHR, about close to 47% of clinicians working in teams with lower cohesion reported this outcome, compared to 55% for clinicians working in teams with higher cohesion. That's before the integrated EHR. And after we're using the integrated EHR, that number for clinicians working in teams with lower cohesion didn't change much. It went from 47 to just under 49%, and that difference was not statistically significant. Whereas for clinicians working in teams with higher cohesion, that number went from 55% to close to 64% after they were using the integrated EHR. So it's a much bigger difference, and that difference was statistically significant. And we see this pattern for all three outcomes, a very similar pattern. And I think, most surprising to us is the results for the last coordination outcomes, so access to complete and timely information. So if you look at those results, for clinicians working in teams with lower cohesion, that number did not really change at all after having access to the integrated EHR. So it went from 33% to 32%, so really no change. Whereas for clinicians working in teams with higher cohesion, that number went from close to 38% to 54% after EHR. So, it was surprising to me that there was no change for those clinicians working in teams with lower cohesion. And I was skeptical that maybe what was happening is that, there's some very grumpy clinicians that are just saying that their team environment is very bad and that nothing good ever happens, and they're really driving these results. And as a sensitivity analysis, what I did is I created a team cohesion score that excluded the individual clinician that was reporting the coordination outcome. So it was a score based on the other members of their care team, but not the clinician reporting the outcome variable. And when I did that, the results were essentially the same. So that gave me a little bit of reassurance. And the other thing that's surprising to me is that overall, even with use of the integrated EHR, I think the percent of each outcome is still fairly low. So before I go on to my conclusions, there are a couple of limitations that I should mention. First, all of the data was collected from a single integrated delivery system that's implementing a very specific EHR system. But, it's not clear that these relationships would apply at different care settings. But I think as more and more care delivery providers move to the accountable care organization model and adopt electronic health records, I think in the future they're going to look more and more like the Kaiser system. So I think these results, are useful a little bit in, what we could see in the future. I think the other big limitation for my study is that my care coordination variable and the team cohesion variable are both based on self-reported data from surveys that had limited response rate. But I think, looking at both, trying to measure the team environment and team relationships, I think there's really no good automated way to do that. And likewise with care coordination, I think the variables, the dimensions that I was interested in care coordination, I think are really, there's not a clear way that we can measure them using automated data. So in conclusion, the improvements in care coordination associated with use of the EHR did vary significantly by level of team cohesion. We found significant improvements for clinicians working in teams with higher cohesion, but no change in these clinician-reported measures of care coordination for clinicians working in teams with lower cohesion. So it's very important to consider the organizational environment and specifically team member relationships when trying to understand the effect that the EHR has on care quality and care coordination. We found that clinicians working in teams with stronger relationships were able to more successfully leverage the various different tools available within the EHR in order to achieve greater improvements in care coordination. And we think that any efforts to really promote use of the EHR in order to improve care quality and care coordination should not ignore the organizational context in which these tools are used and maybe include some combined interventions that focus on team relationships and team functioning. Thank you.
Thank you, Dr. Grates. Our next presenter is Dr. Anuj Dalal. Dr. Dalal is an associate professor at Brigham and Women's Hospital and an instructor at Harvard Medical School. He completed his residency in internal medicine at the Hospital of the University of Pennsylvania in 2004 and holds a graduate degree in medical informatics from Oregon Health and Science University. Dr. Dalal's research interests include developing and evaluating innovative health IT strategies to improve the delivery of care. He was awarded an R21 grant from AHRQ to study the impact of an automated email notification on physician awareness of tests pending at discharge. Dr. Dalal, you may begin.
Thank you. Hold on one second. I'm trying to get control of the slides.
Go ahead and click on the slide itself, Doctor, and then use the keys on your keyboard. Go ahead and click back on the second slide deck at the top, please. No, yeah, there you go. Now take your mouse.
All right, here we go.
Thank you.
Sorry about that. So my name is Anuj Dalal. I'm a physician at the Brigham and Women's Hospital, and today I'm going to talk to you about an automated notification strategy for managing tests pending at discharge. I'm going to mention this term, test pending at discharge, a lot going forward, so I'm going to use the acronym TPADs. So there are two parts to the talk. The first part I'm going to talk about the design and implementation, and then the second part of the talk I'll talk about our evaluation study. So you may, if you read the New York Times, you may have come across articles that talk about this issue that pops up, and this was an article in one of the columns of the Well blog of a patient who had acute abdominal pain, was taken to surgery, had an exploratory laparotomy done, and they didn't find anything. The surgeon astutely sent urine porphyrinobilgens as part of the workup. The patient was discharged. Unfortunately, the patient was readmitted with abdominal pain again, and this time to the medicine service, and they called the GI consult who looked at the results from the prior hospitalization and noted that they were markedly abnormal. No one actually followed up on the results. And what they do in this article is that they point out that in this case, there was a problem with the system. And so in 2005, Dr. Roy at our institution first identified the epidemiology of this problem. He basically observed that about 40% of patients are discharged with TPADs, and about 43% of those results are abnormal. The majority of them are microbiology results, and the other ones are evenly split among hematology, chemistry, and pathology results, and then 27% for radiology. And the big issue the concern that they noted was that 9.4% were considered potentially actionable by independent physician review. And then finally, physicians were only aware of 40% of these results. So, few institutions have standardized systems to manage this patient safety concern. And so you could ask about discharge documentation. Discharge time, this is a review by Kripalani et al. and JAMA on the timeliness, completeness, and accuracy of information transfer hospital discharge. And the two things I'll point out is that there's a lot of information that variably gets to the PCP's office in time. And with regard to test pending at discharge, it only appeared 65% of the time in discharge summaries. And so there's a lot of information there, but are we transferring timely knowledge? And so if you think about it, the fundamental problem is really getting the right information to the right person at the right time. And so why not use Health IT? Well, we tried doing this actually after Dr. Roy's first study in 2005. We have this robust ambulatory results manager system integrated in our electronic health record. It's called Results Manager. And we basically turned this on for the hospital setting to see if physicians would use it. And what we learned is that to be successful, if we use HIT systems, it needs to conform to the workflow of both the inpatient and the ambulatory providers, because the Results Manager is only used mostly by ambulatory providers. The inpatient doctors actually just didn't use it. It also needs to support coordination of care across care settings and promote a seamless transition of knowledge and responsibility. And then finally, it must facilitate test result acknowledgement. So with that information, we decided to try a new strategy to improve awareness of these test results. So we got some internal funding to develop an automated email notification system, which basically identifies patients discharged with TPADs. It notifies the responsible physicians of the finalized results of TPADs using secure network email at the time they become available. And this information is emailed to the discharging inpatient attending, and it carbon copies of primary care physicians, and only for in-network PCPs. And we have three separate notification types, one for chemistry and hematology results, one for radiology and pathology results, and another one for microbiology results. And so the system is essentially a coordinated sequence of events. It is initiated by the discharge time entered by a unit clerk on the floor when a patient's discharged. That triggers the system to identify providers from administrative databases. The system then files TPADs in a queue and excludes selected TPADs based on configurable rules. At midnight each night, it updates the status of the TPADs such that if any of them are finalized, it shoots an email to the inpatient attending and CCs the network PCP. And this process repeats itself until all the TPADs are finalized. And lastly, this process occurs for the three different notification types. So to summarize, it triggers emails until all non-suppressed TPADs are finalized. It limits one email to provider per notification type per day, and sends emails to inpatient attendings and network PCPs. So, we thought about the volume of notifications that this could potentially generate, and as you can imagine, we were a little bit concerned about the phenomena of alert fatigue, the idea that we're going to be inundated physicians with alerts and they'll just sort of ignore them. And so our goal was to maximize utility of timely notifications of relevant results. But this raised some important questions. Should we notify providers of only abnormal results? Should we notify them on negative results? And if so, which ones? Should we exclude some commonly ordered inpatient tests with fast turnaround, such as, the typical basic metabolic panels, CBCs, and coags? And it wasn't clear to us at first, so what we did was we incorporated logic to suppress certain inpatient-specific non-essential TPADs, which were modifiable on the fly. We kept these rules to a minimum during the pilot period to see what was coming through. And so we suppressed things like ABGs, VBGs, components of the CBC, such as the RBC count, MCHC, differential count. And then there's some studies in radiology that really didn't have any impact on decision-making, like the use of fluoroscopy during a procedure. And finally, like outside hospital images, they don't generate in a report, so emailing notifications didn't seem to have any point. And for pathology microbiology, we did not suppress any of those results. But we did. We also limited notification volume to no more than one email per notification type per day until all the TPADs were finalized. And for micro alerts, because of the sheer volume of them, we also only sent subsequent notifications after the first initial notification on the abnormal results. So this is an example of what the configurable system looks like. We're still using fairly old technology, but the point of this slide is just to show that we could go in there and we could toggle with which tests we want to include in the notifications and which tests we want to exclude and suppress. So if you're sitting on your desk, this is what one of the notification emails looks like, and I spent a lot of time sort of figuring out what is the subject line, how we wanted to grab people's attention, and we came up with this subject line: important post-discharge test results, and that seemed to grab people's attention. It's probably arguably one of the most important parts of the study. If you're on your mobile device, this is sort of what the notification looks like on your mobile device. So just to take you through a series of result notification emails. So this is a typical chemistry hematology notification email. All the emails have the date on which it was sent. Identifies the inpatient, the discharge and inpatient attending, as well as their contact information. It identifies the name of the patient, their medical record number, as well as the discharge date. And then it also identifies the primary care doctor, and as well as their contact information. And for patients, for PCPs who are not within the network, it clearly says that the PCP did not receive this notification. But the idea is that if the hospitalist received the email and the PCP's non-contact work phone number, that they can initiate some kind of communication. So at the bottom of the email are the results, and the finalized results are appearing at the top, and the pending results appear at the bottom. So in this case, the antithrombin 3 and factor V Leiden were resulted, but the cardiolipin antibodies were pending at the time of discharge. The next day, those antibodies returned, the results returned, and so another email goes out with those results appearing at the top. The antiprothrombin, however, is still pending. So on the following day, when that's reported, a third email goes out. So in this case, the patient, the inpatient attending, received 3 email chemistry hematology notifications on this patient. So in this part of the study, we were interested in looking at the background performance as well as the email notification performance. And so by background performance, what I mean is sort of what's happening under the hood. So we're interested in the volume of TPADs that were being processed, the percent that were flagged abnormal, as well as the reliability of the discharge timestamp and the provider identification. And by email notification performance, well, what did the physician see? So we're interested in the volume of notification by discharge patient, provider, and test type. So going back to the system diagram, we looked at 83 discharged patients over a 1-month period who were discharged from the general medicine cardiology service, and we noted only one incorrect discharge timestamp that was entered. The system on those 82 patients detected 405 chemistry hematology TPADs, which ended up being about 4.9 per patient. About 65% of those were chemistry, and 35% were hematology, and 18% were flagged abnormal. Based on the rules that we had configured, it suppressed 19 results, all of them which were hematology. And it triggered a total of 136 emails, about 1.7 alerts per discharge patient, and 2 or more emails were triggered on 34%. So what about that one incorrectly entered discharge timestamp? Well, apparently what happened was the unit clerk inadvertently discharged the patient on day 4 of a 10-day hospitalization and triggered the system. And just based on that, the system for those remaining 6 days in the hospital detected 510 TPADs and triggered 9 emails inadvertently to physicians. And the point is that this is a rare event, but it really is dependent on the system to be working, and the manual entry and to be occurring accurately. We also received 3 responses from physicians on 3 distinct patients claiming that the email was sent to incorrect providers, and 2 of them were from inpatient attendings, and 1 of them were from a PCP. Looking at email notifications that were actually sent to providers, this is a diagram of email notifications on 95 discharged patients after all their TPADs were finalized. And as you can see, the majority of them were microbiology results, as you would expect. For inpatient attendings, they received about 1.6 alerts per discharged patient, and network PCPs received about half of that, and the reason why there was a gap was because about half of our patients have non-network PCPs that are admitted to our hospital. So just to conclude on the design, we found that this strategy is feasible and reliable for managing test results pending at discharge and compatible with workflow, but that successful implementation is dependent on accuracy and reliability of the discharge timestamp, as noted by that one incorrect discharge timestamp that triggered the system, as well as provider identification. Basically, if we don't have those 2 things right, then you essentially get the garbage in, garbage out phenomena. So the system will fail, send emails to the wrong providers if those things are not identified. And really, the assumptions we made, because we had those processes working pretty well at our institution, we felt that this would be a reliable way of notifying clinicians of test pending at discharge. I also show that there's a high volume of test pending at discharge, and this is sort of challenging to negotiate, but having the logic to limit this volume and frequency of the notifications is important to minimize alert fatigue, and then having to use a configurable system to modify these suppression rules is desirable. So the key features of the pilot, it recognizes and highlights TPADs as an important subset of test results. It reliably identifies the responsible provider and includes contact info for non-network PCPs when available. And opens a communication thread with the PCP at the time potential actions needs to be taken. So this idea of transferring knowledge, and finally, it facilitates transfer responsibility to the next provider. So there's a way to when an inpatient doctor received an alert and the PCP gets carbon copied on it, they could sort of acknowledge that they have reviewed it and someone's going to take action on it. And then finally, we talked about the logic and configurable rules. In the next part of the talk, I wanted to talk a little bit about our evaluation study. And basically, we had 2 questions. Did we improve awareness, and did physicians like it? So the aim of this study was to evaluate the impact of the automated notification system with regard to inpatient attending awareness of test pending at discharge, and secondary outcomes of PCP awareness with regard to these test results, as well as overall physician awareness of actionable test results, and then finally satisfaction with the notification system. So we did a physician-clustered RCT. So basically, we activated a system for independently randomized inpatient attendings and PCPs. And we did this just on the inpatient general medicine and cardiology services from October 2010 through May 2011. And then we surveyed the intervention and control physicians with regard to their awareness of TPAD results, and as well as their satisfaction with the system. I'm going to talk a little bit about the randomization scheme. Basically what we did we randomized a physician pair such that so the inpatient attending and PCP were randomized independently, and we only included patients if both the attending and PCP were concordantly randomized. So we excluded patients whose inpatient attending and PCP were discordantly randomized. And the reason why we did that is that because if a PCP received a notification email, they could have made a control attending more aware of the test result, and that could have skewed our results when we surveyed physicians about their awareness. And that the same is true if for a PCP who is in the control arm and an attending who is in the intervention arm. And so discharged patients with TPADs were identified by the notification system and assigned to an intervention or control by this randomized physician pair. So after excluding about half of those physicians, we ended up with about 500 patients with TPADs whose physicians were randomized to concordant arms. About 241 patients were assigned to the intervention arm, and 200 were assigned to the control arm. Now there was a quirk with the system such that we were not able to identify the PCP on about 50 patients in the intervention arm, as well as about 30 patients in the control arm. To talk a little bit about that, but it is a little complicated, and so I just wanted to, if people are interested, they could ask a question about that, and we certainly could talk about that. But the bottom line is that it required that that the administrative personnel match up the name of the PCP correctly and enter it into the system, and if it didn't, then basically the system didn't detect patients with the PCP. So the system generated an intervention arm 139 surveys completed by 39 attendings, and then finally we looked at for our data analysis we looked at 139 surveys completed by 39 attendings, and then 67 surveys completed by 50 PCPs, and in the control arm about 136 surveys completed by 41 attendings, and 82 surveys completed by 61 PCPs. So looking at the baseline characteristics of intervention and usual care attendings, in general they were about the same. Perhaps there was a little more attending experience in the intervention versus the control arm. With regard to the discharged patients, in general their characteristics were pretty well matched across both arms. So looking at the primary outcome, in the intervention arm, we noticed that we observed that 76% of intervention attendings were aware of TPAD results, whereas in the control arm, only 38% were aware. And this was similar to what Dr. Roy had initially observed in his study in 2005. And this was in the crude analysis. This was statistically significant. I don't have the adjusted analysis here, but when we did the adjusted analysis and the clustered analysis, the significance held as well. So for our secondary outcomes for awareness of any TPAD result by PCP, we also show that there was increase in awareness of any of the TPAD results by PCP, 57% versus 33%. And this was true for network PCPs, but it didn't really hold. It didn't really hold for non-network PCPs. And as you could look by the numbers, this was probably because the numbers are really, really small. We also asked the physicians to determine whether any. We asked about if they took action with regard to any of the test results that were coming through the emails, and then we looked at their awareness, and we also noted a trend towards increased awareness of actionable TPADs, primarily for inpatient attendings, but it looks like there was a trend for PCPs as well. So with regard to satisfaction, so asking about physician satisfaction in usual care, there was most physicians reported, inpatient attendings and PCPs reported that they weren't satisfied with the usual care of managing these test results. In the automated email notification arm and intervention arm, most of the physicians, inpatient attendings and PCPs alike, reported that they were satisfied with the way the system was configured. So here's some of the comments that physicians made. This one said that they were unaware of the test that was even being ordered. Had it not been for the auto notification, would never have known about the test result, but didn't really call it PCP because the test result was in normal range and didn't think it would affect management. Others thought that the concept was great, but all the notifications I received were on negative results. Might be worthwhile for blood tests only if it was abnormal. Another person thought the results were clear as well as the train of ownership. So in conclusion, awareness of the finalized TPAD results under usual care is still poor, but that physicians receiving automated email notifications are significantly more aware of TPAD results compared to usual care physicians. And we also showed that intervention physicians are highly satisfied, but that physicians vary with regard to the type of results they wish to receive. There are some limitations that I would like to point out. We have a robust culture of using email by inpatient physicians as well as our PCPs. And this was sort of a small sample size, and we only powered to detect difference in awareness of any test result, not actionable test results. And finally, generalizability. We are a single institution. We looked at only 2 services, mostly medicine services, and we used our proprietary systems. But I think this study has some important implications. We think it's a promising strategy to prove awareness of otherwise a gap in an important patient safety gap that has not yet been resolved. And I think we need to do more additional studies to really see if receiving notifications in this way impacts downstream actions taken, and also trying to elucidate desired features to maximize utility for physicians. So, for example, is there a way of electronically acknowledging these test results in the email once they arrive in their inbox? And then finally, other studies could demonstrate effectiveness for other clinical services, hospitals, and as well as other electronic medical record platforms. Thank you.
Thank you, Dr. Dalal. I just want to remind the audience that you can submit questions at any time. We're getting a few in, but just wanted to remind you. Our final presenter today will be Dr. David Dorr. Dr. Dorr is an associate professor and vice chair for the Department of Medical Informatics and Clinical Epidemiology at Oregon Health and Science University. He completed his internal medicine residency at OHSU and earned a master's degree in medical informatics and health services administration from the University of Utah. Currently, Dr. Dorr is the principal investigator for the OHSU Senior Care Program known as Care Management Plus. Care Management Plus is a technology-intensive, innovative primary care model that reduces hospitalizations, lowers costs, and improves health outcomes for older adults with chronic illnesses. Dr. Dorr, you can begin.
Thanks. So that was a very nice and succinct introduction. I appreciate it. So this work is really about redesigning primary care to improve care coordination and care management for the most at-risk patients in practices. It has implications more broadly around teams that work with these kinds of patients, but most of the studies I'll talk about are really focused in understanding how we can improve primary care through a variety of techniques. And I'll discuss research that was funded initially by the John A. Hartford Foundation at Intermountain Healthcare, and then one of the trials I'll discuss was funded through HRQ. And then the Gordon and Betty Moore Foundation have funded us to do a new study looking at patient-centered medical homes as well. We really focus on patients like Miss Vieira. So Miss Vieira here, 75-year-old woman. She has 5 chronic conditions. And we know that her chronic conditions are not going to be well addressed in an individual primary care fee-for-service visit. She'll come to clinic with 5 to 7 issues and then often have multiple hallway issues as you're reaching for the doorknob that she's concerned about, like her husband or her caregiver, her adult daughter caregiver, are struggling with their financial needs, or that she's had a recent episode of falling and passing out. And so what we struggled to do is figure out what a primary care team can do to really help her take care of herself better, stay safe at home, maintain her functional status as much as possible. So I drew this algorithm, or picture, I guess, of what her care might look like in the upper left-hand corner as a standard usual care system. And I did this for a group of engineers initially to try and help them understand what this looks like. So a little bit of explanation in regards to this. Here we have Miss Vieira, her various family members, her caregiver, and what you see is that there's all these arrows going to lots of different places, including to a primary care team, including to specialists, and they're all talking to each other, and then up in the very top is her care plan, her treatment plan, multiple chronic conditions, multiple medications. We know that on average, a person like Ms. Vieira will see 12 to 14 physicians a year, about 8 ongoing relationships over time. She'll fill 50 prescriptions over the year, and her risk of hospitalization, in part due to this fragmentation and all these touches that are uncoordinated of her care plan, is 90 times the risk of somebody without multiple chronic conditions. So what we tried to do is think about what are the potential places we could improve this. And one of the ways was to reorganize the primary care team in some of the ways that you heard from the first presentation, to have a multidisciplinary team, and we focused on making sure there was a care manager or care coordinator, and really trying to redesign the health information technology so that an up-to-date list of her treatment plan, her care plan, her value and preferences could be aligned and kept in a single place. It's a little bit like shooting for the moon, but at least we felt like we had many places to make improvements. So the old system I like to call heroics. So what primary care clinics used to do in this setting was just struggle and work and try and do everything they can to help the person and their family stay on top of this, because the risk increases exponentially as you have more and more chronic illnesses. It's not just a linear increase, but really it goes up so fast. And really what dominates that risk of poor outcomes is not just process scores for meeting particular guidelines like quality measures. It's really related to their functional status and their ability to understand and prioritize based on their own values what needs to happen, because we see that even as patients meet their quality measures, they were still ending up in the hospitalizations. And so we created this model at Intermountain Healthcare, and what we found is that you could create a care management system within the clinic, that you could have referrals that were often directly, in fact, face-to-face from a provider, and really for any condition or need. We did not set it up so that it had to be diabetes or heart failure or a particular condition, but we did sort of train them in protocols to focus on certain conditions like diabetes, like depression or other mental health, or multiple chronic conditions together. And then the care managers would work with the patient to assess and co-create a plan, to be a catalyst to see that plan go forward, and be a structure within the clinic to understand how we to understand the needs of the patients, and also if a crisis arose, as it so often does, that they had improved access to the team. And then technology was rebuilt based on the needs of the care manager. So actually the care manager redesign, the team redesign, including the care manager, care coordinator, was the start. And then the technology was built on top of an extant home-built electronic health record. So the current health record that was at Intermountain Healthcare was not felt to be enough for these care managers, and they told us they needed to access and add to that care plan more readily. They needed reminders about best practices in slightly different ways that I'll show, but also the ability to set their own reminders about things that the patient valued or that they were really worried about, and to facilitate in a prioritized way closing the loop on communication, not just with the patient and their family, but with many other groups. And then there was an evaluation component built into the study, but also the care managers were taught to go back to the providers and the team with feedback about how it was going, to have early wins in terms of how things were going with successful patients and what they were struggling with, increasing that local communication, and then also they were given reports on key process and outcome measures. So we did a whole bunch of studies on this, and I summarized them here very briefly in terms of time, but really showed an improvement in the triple aim of healthcare. So we published in 2005 in Health Services Research about improved diabetes outcomes, and there's been since a review for nurse care managers focused in diabetes alone that they really have significant improvements in A1C control and understanding their illnesses. We also showed improvement in depression outcomes in terms of the severity of depression through this. We also showed improvement in experience of care through a series of qualitative studies we did, interviewing patients, interviewing care managers, and interviewing providers and observing their interactions. And what we saw is that there was some really impressive experiences that they had in really understanding and getting to the core of what they needed in terms of their care, really rather than focusing on them as a set of individual diseases, but rather focusing on them as a person who had values and preferences and risks that they wanted to work on, and helping them to learn to self-manage was very valuable across these groups. And then we also showed a 24 to 40% reduction in hospitalizations. That's at 1 and 2 years, and about a 2-to-1 cost savings. And all of those references are given at that website there. So what we've been doing since then, we got a second grant from the John A. Hartford Foundation to disseminate this by trying to understand what it was in the 2-year ramp up to our initial study was most effective in the training and the IT of the particular successes we saw at Intermountain. What was it that was helpful there? And especially thinking about Intermountain Healthcare as a large integrated delivery system. And a lot of these broad studies in HIT and care coordination redesign are often started in those places, but may not be applicable to individual private clinics or other settings of primary care where, honestly, most people get their primary care. So what we discovered by sort of reflecting on this and doing our subsequent follow-up studies was that there's a really crucial aspect to team readiness, that really getting the right team with the right training is a core principle. And actually that sort of education goes right to the patients. They really need to know how to self-manage. They need a guide through what is often a complex and confusing and fragmented healthcare system. That care managers really needed specific training. And since we've done the study, there's been a lot of focus across the country on care managers embedded in primary care or as part of different initiatives, including the patient-centered medical home or accountable care organizations. And one of the things we often hear is that they might pick a nurse in the clinic or a social worker or someone in the clinic who was doing a previous role and now doing a new role, but there's not clarity about what role they should be doing. And so the training that we've found to be really helpful is how you educate. And we have to reflect that after an average primary care visit, about 50% of patients understood the goals and the expectations that they set during that visit. Motivational interviewing is a big part of that. Setting goals together, avoiding resistance for patients, especially with complex illness, and coaching similarly. And then there are disease-specific protocols, diabetes, depression, cardiovascular illness, and also we found that a lot of people were at risk of becoming frail as either older adults or with people with multiple chronic illnesses were at risk of losing their functional status. And they were often cared for by someone, so we focused on care for seniors and caregiver support and connection to community resources. And then providers and other staff also needed this information. So in order to really participate in the team approach to this work. So the IT components are really interesting, and we're seeing more and more happily that we're starting to build these, but they weren't in the electronic health record system, and that's because electronic health record systems are built for billing and documentation. They're transactional systems built to manage individual visits or encounters for patients and make sure there's enough documentation and that you can drop the appropriate bills. But really what they needed was prioritized population management, a completely different approach. And so this is one of the things that we built, a way for them to generate risk lists of patients. And here, for instance, is a very simple high-risk patient list with two different components. Here, where the clinic can set one, or it can be set through a standard algorithm that we published on in 2006. And basically, this was pulling from the 10,000 or so patients in the practice, the 500 or so, or maybe 1,000 that really at higher risk for hospitalization, for poor outcomes, based on their multiple chronic illnesses, based on their previous utilization, if that was available, or other mechanisms. And then we found, and this is sort of a common issue in a lot of team members for EHRs, is that they were overwhelmed with messages, that the system was generating a lot of workflow messages and messages from people, and they were unable to sort of get a single task management tickler list about what's important, either from their perspective or from a patient's perspective in terms of goal setting and follow-up, or for care coordination, really high-value care coordination elements like follow-up after an ED visit or hospitalization. And so we built in a particular way to bring that all together and then be able to basically go through those and mark them off as they're working with patients. So really managing their workflow, which enabled them to see more patients. And then we also built a series of quality reports. These are fake patients, of course, but the idea here was a population management that's not just a static report, but enables you to really work with it in terms of care coordination and care management to identify people who are really struggling and who might benefit from more intensive care management. This was in part from experiences on the teams where they were literally just seeing the same list over and over, the same people, and they ended up spending 15 to 20 minutes of it just saying, no, we've tried and we tried with this person, or this person's really doing fine. I don't know why they keep on showing up in the list. So we basically enabled them to have a tailored list that they could identify a subset of patients to send to care management and the rest to either exclude from this particular report or move off from the practice easily. Now, this is all in the context. I'm going to shift here a little bit to the ICIS system, which I apologize for not spelling out. ICCIS is the Integrated Care Coordination Information System. One of the biggest issues we found in our work is that outside of an integrated delivery system, often the clinic struggled to get the IT resources to get the information they needed from the EHR into a different population management system or into a form that they could use. And so through a grant from AHRQ, which is called the Integrated Care Coordination Information System, we said, how can we help people to solve this IT dilemma or give them a pathway to do it, as well as really help them to find the right incentives to do this work. within their clinic as a way of setting policy, as a way of really extending our understanding. And so one of the things we found is health information exchange was really struggling, that people couldn't get the information they needed across sites. And so we really focused on a subset of that problem by saying what's really important in our experience in care coordination and only mapping that targeted information. And so we actually, over time, have worked with 7 different EHR systems to find that data, to standardize it into a structured, simplified version that is optimized for this kind of population management and risk. And so it can be done. That was one of the big challenges that we had as we moved this out is this, from an IT perspective, possible? Absolutely. For even the legal and other socio-technical issues can be solved. But this is quality improvement and care coordination, so it's really covered under much of the Privacy Act. So that trial basically enabled us to really take our previous approach, building this system that had been built initially at Intermountain, and provide the training that we defined, and then we could set different incentives for the teams. And in that incentive setting, we took one and sort of used the medical home-based care coordination type effort. So in Arm 1, we basically randomized a group of clinics to receive modest incentives for collecting data on coordination of care. And the other arm, we focused on quality. And in that arm, we basically said, you just need to improve your quality measures much like you would for any standard pay-for-performance. And this was a couple years ago. It started in 2009. So this was sort of an interesting, novel concept. And then at the end, our goal is to really look at, which of these moves the triple aim outcomes more, especially avoiding poor outcomes for patients at risk. And so we structured our analysis to focus on the high-risk patients from both of these groups, and then seeing which of these affected their patient satisfaction and their healthcare costs. So one of the first things we saw, which was really impressive, even though our incentives were really modest, it wouldn't have even paid for a care manager by itself, we saw they were very responsive to the incentives. And here you see the quality arm, and this is absolute increase in quality measure performance. So if you imagine here at quarter 1, they were 50% on a set of measures. They moved to 64% on a measure like A1C control or something, or LDL control. And the quality group in blue did outperform the care coordination group, but you'll note that there's about a 10% increase as well in that group. And part of this is that, they're closely related, and that by solving a little bit of the IT dilemma, they were able to actually reflect on their performance much more easily. Now, the care coordination activities were also significantly increased overall, but much more so in the care coordination group. Now, so a little bit of a long table, but basically we reimbursed both arms for care managing patients, for identifying who they're care managing more intensively, and for sharing patient summaries, the sort of meaningful use style clinical summary sharing. Arm 1, which is the care coordination arm, we basically saw that they had almost twice as many care coordination style encounters or activities than the quality arm. So 1.8 to 1, and we're seeing this is 12,000 encounters during the study overall. And you can see that it varies a little across the high-value ones. They were much more likely to do assessments and education. Goal setting was low overall, in part because we required them to follow up on the goals, and that was difficult, but slightly more in the quality arm. And then communication was much more effective for the care coordination arm. And then Arm 2, interestingly, was actually supposed to be doing quality encounters, and part of their incentives were tied to doing clinical protocols around hypertension care or changing their statins, for instance, for LDL control. And they we actually saw the care coordination group was still doing more of that, mainly because they were really focused on engaging the patients in a particular way. Now, unfortunately, I don't have the final results for this yet. The study ended in mid-2012, and we've been working hard on sort of getting the final results. But I presented at Academy Health that there seemed to be, at least with initial data, a reduction in hospital days for these groups that was potentiated by the group that they care managed across both clinics. So the incentives affected had a reduction in hospital bed days for care coordination versus quality, but also if they care managed them, it was much stronger overall. So this sort of identification and tracking of who you're doing intensive care management ended up being important. Well, what we've seen since then is a really complex set of health reform changes, and this is summarizing a bunch of them, but we see mixed effects, basically trying to move people towards this more care coordination model. And we in Oregon are either a little crazy or perhaps just really assertive in trying to roll out health reforms, and what we've started to do here is take both a patient-centered medical home, which we call slightly different name of the patient-centered primary care home, and do an accountable care organization model at the same time. And what we wanted to know is, can we take the results that were successful in improving these downstream outcomes, like our original study for Care Management Plus and like what's been shown at Group Health and Geisinger, and can we actually help in these broad-based, large-scale health reform with lots of different points they're focusing on, improve their outcomes? And so what we ended up with was this, a much more simplified version where we basically said, and this is funded by the Gordon and Betty Moore Foundation, we're going to do another cluster randomized controlled trial. It literally started 2 weeks ago, so very early on. We do the same sort of evaluation for a medical home and assessment and the care management training. And we would help them to focus in the intervention arm on achieving a set of what we call high-value elements and give them a multiplier for the incentives for those. So compared to your standard patient-centered medical home where you might have 3 tiers and you might get paid a little bit more for those highest tier, we're really focusing on, are you doing really intensive care coordination? Are you reaching out to 25% of your patients that are at risk or 50% and doing care planning and doing goal setting? And so that in the intervention arm is really what we're driving to. But since we did our first trial, we found that practice facilitation is really a crucial aspect of transformation in these clinics. And we're working with the Oregon Rural Practice-Based Research Network, one of the funded practice-based research networks from AHRQ, to really provide evidence-based practice facilitation to them. And in that group, the intervention group, they're just trying to help nudge them towards those higher value elements. And we use the IT really as a base. It's not really this, it's just so they have the information if they want to use it. In the control group, we're really trying to see that they're working on transformation in a more generic sense, and that they're really engaged in the process of transformation to being patient-centered primary care home. And this is really nicely aligned with a number of initiatives that I won't have time to talk about, but trying to move everybody towards the same goal and understand primary care's role in it. So here are our high-value elements, and basically we drilled down to a series of articles, including a set by Randy Brown, who's done a really good job in understanding evidence from the Medicare Coordinated Care Demonstration and other studies to see what's really important to help groups focus on. So one is, can you identify your patient population at risk, or is it just sort of a standard disease-specific, all your diabetics, whether they're controlled or not, are on a particular registry? And we found that that's a really important component, care management based on what they really need in a timely fashion. Patient engagement and proactive goal setting, the kind of motivational interviewing and focus on how engaged they are with their care and their ability to take care of themselves at home or with help from others. the integrated information and procedures, do they get the kind of information they need, and then making sure that they make use of population management tools to really understand their performance over time. And so those are a simplified version of this since the trial's ongoing. We identified actually about 22 total high-value elements that are sub-measures underneath these. So that's really where we are. So, if I were to summarize what we've done so far, we've built a model, Care Management Plus, and showed some initial positive outcomes at an integrated delivery system with a team-based redesign and an IT redesign. And we expanded that to many teams across the country and are studying ways to better integrate evidence about what really works in care coordination into the health reforms of today. So, obviously I don't do this by myself. There's a lot of people who help us at OHSU and at Intermountain, Sheree, my co-PI, of course, and at Columbia. And here are just a set of links for you that sort of go into more detail and have information. If you want to take a look at what the ISIS looks like, there's a Captivate demo, a flash demo that can help you see that. So that is all I have for this.
Dr. Dorr, did you want to move to the next slide for your contact information?
Sure. That's my contact information.
Great. Okay, wonderful. So thank you, Dr. Dorr, for your presentation. We are now going to move into the Q&A session. It will have about 10 minutes for questions, but I do see that our fabulous presenters have already been answering a lot of your questions directly, so that's great. We don't have very many, and actually the ones that have come in towards the end are for you, Dr. Dorr. I think you already answered, is the ICCIS available for use for other providers?
Yeah, so where we have the system implemented, it's globally available, so the whole primary care team can use it. You can imagine that the people only use tools to the extent that they're really helpful to them, so a primary care provider might review their own panel or their own quality measures, but the care managers are really doing the tickler and intensive use of it day to day.
Okay, another question is, was the ICCIS documentation or a subset updated to the EHR?
Yeah, this is a great question. So it depended on the EHR. Some EHRs it's easier to build information back into them and to build the interface to bring the information back. And our standard approach to this was to identify, could we push a note back with the kind of information that we were tracking in ISIS. And the tickler list really should be thought of as almost a task management system, and so it would sort of bring in, I worked on these issues, I completed this task, I had a telephone call with this person, and here's the topic for the care manager. So it's kind of care management documentation that would replace a telephone note in the EHR. We really tried to steer people away from documenting like labs, unique labs in the system because in ISIS, because that's in the EHR and we don't want to duplicate any information, and we'll just pull that into ISIS. So notes, yes, for some EHRs.
Okay, thanks. And I just want to pause really quickly because we're getting a lot of big questions about copies for the presentation. And I just wanted to remind everyone that these slides, the audio, and transcripts will be available on our website in approximately 2 weeks. That's www.healthit.ahrq.gov under the Events tab on the left-hand side. And so let me go to the last question for Dr. Dorr. Someone comments, care coordination success depends on how effectively patients can be transitioned from hospital to multiple care settings. With many different flavors of EHRs, how do you suggest EHRs can help these care settings connect, communicate, and share information?
So I think the first part of that question was actually asking about care transitions. So obviously, at care transition from a hospital to home, for instance, is a crucial time to figure out how we would communicate information and make sure people have good follow-up plans. And to date, there's been some really successful trials in using transition coaches, like the Care Transitions Intervention, et cetera. But the challenge has been in exchanging data directly from hospitals to primary care places or from primary care settings to specialty settings is that the incentives haven't really lined up. It's not really a technical problem. It seems like it is, but there's not a broad, there's not, the incentives don't really push people to do this in the way that they might. But that's changing as we get things like global budgets for accountable care organizations where you're all responsible together for care coordination and people are trying to figure out how do we do this. And one of the things we've seen, even in the patient-centered medical home model, is there's a lot more interest in trying to get that information, to track it, to put it in a way that it can be reliable. And we've worked with a lot of clinics who go to their hospital and say, I need your ADT information about the patients that are in my clinic, and let's figure out a way to exchange them and get that into our written agreement for the care and follow-up of those populations. But part of the technical solution of this is to keep it simple, to not focus on, I want to see every piece of data and have that integrated, but to focus on, I need a notification about they were in the emergency department, they were in the hospital, and how can I receive that in a way that's feasible now, and then we can keep on working on making that better over time. So that's really helped. Meaningful Use Stage 2 promises to help in terms of the EHR certification and needing to take up things like the continuity of care documents and actually put them into the system so they can be used to generate alerts in this way. So there's some standardization that's occurring that will be helpful, but keeping it simple is probably our kind of dominant approach to this.
Okay, another question has come in. Has there been any interest in using unstructured data analytics like IBM's Patient Care and Insights, a new analytics software?
That's an interesting question. So I think that 90% of medical notes are stored as unstructured text, and trying to drill down into that is a broad area of interest in informatics, of course. And I would hesitate from endorsing a single, I'm not familiar with IBM's particular component, but I think there's a lot of interest in doing that. I think one of the biggest caveats about this is there's some good evidence that as soon as you take the information out of the context in which it was created, you lose about 50% of the value. So you need to be very conscientious about mining unstructured text for content, for concepts, for things that will help us determine risk. If you don't know where it came from and what the meaning is, I mean, this is even true in some structured data like diagnoses, which depending on if they're billing or encounter or actually on the problem list, really have very different predictive validity, for instance.
Okay. I think moving into the final question for the last 5 minutes, I think, again, this is directed towards Dr. Dorr. I like the idea of care management teams. Have you seen this in maternal child care where care is extremely fragmented?
No, that's not my area of specialty, but that I don't actually know, but it seems like it would be beneficial.
And we could open that up to the panel as well if anyone else would like to comment. Okay. Sorry, I don't think we have any information in that particular area at this time. So I would say that this is the end of the Q&A session. Those are all the questions that we've received today. So we want to thank you for joining us today and hope you enjoy the rest of your day. Thank you.
Ladies and gentlemen, that concludes today's web conference. You may now disconnect your lines. Thank you and have a wonderful day.